will also develop COPD because of exposure to pollutions and biomass. So majority of the cases would be environmental COPD. But we have some genetic predispositions for COPD. So this would be genetically predetermined. And then some our COPD is related to infection, and some is because of a developmental problem. So the developmental problem would be seen among individuals who are born prematurely or small for gestational age or underweight uh, babies among babies who have a frequent illness affecting the lung. Okay, sometimes they would also develop COPD quite early in life. Okay, so we also have the COPD asthma overlap, and of course a small number of patients with COPD do we cannot identify the cause. Okay, for genetic predisposition, the number one risk factor for the development of COPD would be your alpha 1 antitrypsin deficiency. Okay. So, what is the problem of patients with COPD? Among patients who have COPD have airway obstruction. Okay, so and the airway obstruction is not like your asthma, wherein the patient's airway obstruction is reversible. But the airway obstructions of patients who have COPD are usually is not reversible. If it improve with management, with treatment, generally the improvement in their airway resistance is not that significant. Okay, so among patients with COPD, this may be results of your airway problem or emphysematous problem. So all the airways are involved, not only the small airway, but also the large airway. So small airway may become narrowed or obstructed by hyperplasia and accumulations of mucus and fiber, and there may be also a destructions of the very small airway among patients who have COPD. Okay. So the problem with your COPD is that this mostly would be because of exposure to noxious substances, mostly your cigarette smoke. Okay, and this would trigger an inflammatory or immune response to recruit inflammatory cells into the small airway, and these inflammatory cells will subsequently release proteins that would now cause the damage to the extracellular matrix supporting structure of the airway, and this can lead to destructions of the small airway, and this can also cause vascular and gas exchange problem. Okay, because of the destructions of the um, supporting structures. Okay, so in emphysematous patients, okay, especially at the late stage, this may lead to structural cell death, which occur through the oxidant-induced damage. Your cells are this is because of the overproductions of your protease, causing cellular senescence and proteolytic loss of cellular matrix attachment, leading to extensive loss of small airway attachment, causing your obstructions of the very small airway. And with the destruction, the body would try to repair, but the repair is uh, uh, not successful. That's why this would lead now to uh, extracellular matrix component causing uh, irregular irregular repair leading to airspace enlargement, forming emphysematous changes in the lungs. Okay, so there is exposure to noxious substances, and sometimes with ev- uh, sometimes incorporation with genetic susceptibility, but most of the time it's just the suboxidant stress that the patient is exposed to. This would now lead to the recruitment of your inflammatory cells, not only your macrophages, but also your neutrophils. And this can also lead to the damage to the lining epithelium. And with the increased amount of inflammatory cells, these inflammatory cells would release your protease, cytokines, chemokines, okay, which may lead to the destructions of the lung parenchyma, causing apoptosis and cell death. Okay, and if we try to repair, the repair may not be effective. That's why there would be disarray of your repair. Okay, so the most acceptable, okay, theory right now is your in among patients with emphysema is your, okay, elastase anti-elastase hypothesis, which postulated that the balance between the elastin degrading enzyme and their counterpart, okay, is not there is an imbalance, and that's why there would be this can lead to destructions of the lung parenchyma, causing the enlargement of the air spaces of the lung parenchyma. So the alveolar wall would be destroyed, and there would now be coalesce of your different alveoli, causing a very big bullae and leading to the destructions of the the lung parenchyma, causing a drop in your surface for your gas exchange. Okay. So this, aside from the elastase theory, this would be your, what we have said earlier, the oxidant stress from your cigarette smoke, okay, which now recruit the inflammatory cells and produce lead to the activations of these inflammatory cells and activations of your proteinase and chemokines that would now also result in more inflammatory cells and immune cells and lead to the destructions again of the pathology on the airway and the lung parenchyma. So we can also, if our body try to counteract the oxidative stress that the patient is exposure by the major by the transcription factor NAFA-R F2. Okay, so this is one of the response of the body to the oxidative stress that your patient is when they are exposed to the pollutions or the cigarette smoke. Okay, and in among patients who have COPD, there is also mitochondrial dysfunction, which can further worsen the oxidative stress of the lung that is affecting the lung. Okay, so the mitochondrial dysfunction is because of the activations via the oxidant-induced inactivations of the histone deacylase, shifting the balance towards an open chromatin, exposing the nucleus factor kappa beta site, okay, resulting in transcription of matrix melatoprotein and more inflammatory cytokines like your interleukin and your tumor necrotic factor, leading to your neutrophils recruitment, causing more inflammations. Aside from that, your CD4, CD8, and T lymphocytes are also recruited to the lung parenchyma, and this can cause release of your interferon inducible protein T, which in turn leads to macrophage productions of your elastase. Then this can now contribute to the destructions of the lung parenchyma. Okay, so the matrix melanoproteinase and synase protease is the most notable neutrophil elastase that can cause degradations of the inhibitor of your protective mechanism of the body, leading to the lung destruction. So this would be what happens. So there would be proteolytic cleavage of your elastin, and this is because of the chemokines that was released from the inflammatory cells. Okay. So your proline, glycine, proline, okay, is a neutrophil chemokines. Okay, so this particular chemokine fuel the destructive positive feedback loop. So this can lead to elastin degradations and disorder repair, and these are the primary mechanism for the development of your emphysematous changes in the lung among patients with COPD. Okay. And aside from this, you can have also autoimmune mechanism which promote the progressions of the disease through the because of the increased number of beta cells and lymphoid follicles that are present in the area of COPD, with particularly those with far advanced diseases, and you also this can also cause fragmentations of the elastin and causing cell death to the lung parenchyma. Okay. So another actions of cigarette smoke that may induce harm to the lung would be the loss of your ciliary, in of the cilia of the lining epithelium. Okay, and this would lead to increased risk of infection. And this, if there is infection, there would be more inflammations, and more inflammatory cells would go to the lung, and this can also cause patients to have more exudations on the lung, causing added destructions to the lung airway and including the lung parenchyma. Okay, so this would subsequently lead to the cell death. Okay, so the cell death involved the cellular senescence and leads to concept of the emphysema, okay, resembling premature aging of the lung. Okay. And because of the destruction, the body, actually the lung is a very complex structure. So if you try to repair it, it will usually be incomplete and lead to an erroneous or eradicate repair, can causing the more of the destructions that we see among patients with COPD. Okay. So cigarette smoke can cause problem of both the large airways and the small airways, including the alveoli. So changes in the large airway usually lead to the manifestations of cough and sputum production, while the small airway is the contributor for the marked airway resistance. So the airway resistance is mainly from the small airway. So with that, your patients would be complaining of the shortness of breath. But in the large airway, mostly this would be causing changes would lead to the manifestations of cough and sputum production. Okay, so in the early stages of COPD, usually patients would be belonging to stage 1 and stage 2. Okay, this is based on the severity of the airflow obstruction, which is primarily due to the problem of the medium size and the small airway, leading to the airway obstruction. And in advanced states of COPD, stage 3 and stage 4, this is typically characterized by extensive emphysema. And this is also the greatest risk of progressions of COPD, and those with both aggressive airway disease and your emphysematous changes of the lung. So mostly the if the patient have very severe COPD, it is expected that they would have quite a lot of emphysematous changes already in the lungs. Okay. So In the pathology of COPD, if your patients have emphysema, you would be able to see the destructions of the lung parenchyma using your CT scan. Okay. Okay, so the problem with the large airway, usually there would be increased uh, number of mucus gland and hypertrophy of the mucus gland, leading to your sputum production. And because of the cigarette smoke, there would also this can also induce squamous metaplasias of the lining epithelium, predisposing the patients to develop malignancy. And this can also lead to disruption of the mucociliary clearance mechanism, contributing further to the accumulations of the mucus within the large airway. Okay, and we have talked about this already. So the small airway is the major site of increased airway resistance. Okay, aside from that, you can see the changes that we see in the small airway would be goblet cells, hyperplasia, surfactant secreting cells is being replaced by your um, other cells, and there is also smooth muscle hypertrophy, contributing to the airway, more airway resistance. Okay. So the narrowing or the airway resistance is contributed actually by the fibrosis that we see because of the chronic inflammations that is induced by the oxidative stress, the excessive mucus productions because of the hypertrophy and hyperplasias of the goblet cells, and the inflammations can also contribute to the narrowing because the inflammation causes edematous changes of the mucosa, causing contributing to the narrowing of the diameter of the small airway. And aside from that, your there is reduced surfactant because of the change of the surfactant forming cell by other cells, and this can contribute also to the airway narrowing and collapse of the small airway or the respiratory bronchiole. Okay, and this patients would have the destructions of this small airway also seen in more in the periphery, causing narrowing and drop out of the small airway, which precede the development of emphysematous changes of the lung. Okay, so this would be the problem. Okay. So in advanced COPD, there are loss of many of the smaller airway and a similar loss of the microvasculature, which also contribute to the changes in the blood gas of patients with severe COPD or what we call their advanced COPD. So in the lung parenchyma, we see destruction of the alveoli. Alveolar wall becomes perforated and later on obliterated and coalesced and leading to the development of your emphysematous airspace. And usually we see this as your bullae, very big bullae. Okay. So what are the different types of emphysematous changes? You have your centrilobular, your panlobular, and the panlobular and paraseptal emphysema. So the centrilobular is frequently associated with cigarette smoking, and this is more frequently seen in the upper lobe of the lung. Okay, so more in the upper lobe. Your panlobular is more frequently seen at the lower lobe of the lung, and usually this is due to your genetic problem like your alpha 1 antitrypsin deficiency. Okay, and for the paraseptal emphysematous changes, this is actually very rare. Okay, seldomly seen. It is only seen around 10 to 15% of the cases. The emphysematous changes is seen in the periphery of the lung, very near the pleura. Okay, and it is commonly associated with significant airway resistance and with centrilobular emphysematous changes of the lung. Okay, so Patients who have COPD have a chronically reduced FEV1 over FVC, and usually there is no significant improvement in your FEV1 over FVC to your bronchodilator. So unlike your asthma, you expect the FEV1, the flow parameters, to improve by around 20% or and 200 ml. But in COPD patients, we do not see this significant improvement of your flow parameters. There may be improvement, but it is not as high as 20%. Okay, so that is the difference between your asthma and your COPD. Both are obstructive disease, but in COPD, there is no reversibility of the airflow obstruction. Okay. So because of the persistent airway narrowing of the airway, this can lead to what we call your air trapping. So when patients who have COPD have an increased residual volume and increase in of the ratio of your residual volume to your total lung capacity, we would say that the patients have hyperinflations of the lung. Okay, so in the long run, initially it may help the patients, but in the long run it would actually cause more, okay, problem to the patients. Okay, why? Because the hyperinflated lung, okay, have flattened would lead to the development of a flattened diaphragm, and the flattened diaphragm would decrease the zone of oppositions between the diaphragm and the abdominal wall. So the positive abdominal pressure that we generally use to help in the inspiration is not applied as effectively to the chest wall as a normal curved diaphragm. Secondly, okay, the flattened diaphragm, okay, causes the muscle fiber of the diaphragm to be flattened. So there is a shorter than it is shorter compared to the normal curved diaphragm, and thereby it is less capable of generating enough inspiratory pressure compared to a normal individual. And thirdly, the flattened diaphragm must generate greater tension to develop the needed transpulmonary pressure required for tidal breathing. So this is the third side adverse effect of the flattened diaphragm. And fourthly, the thoracic cage is distended. If you have a hyperinflation, this will cause the thoracic cage to be distended beyond its normal volume, and therefore, during quiet tidal volume, the inspiratory muscle have to work harder to overcome the resistance of the thoracic cage to further inflate instead of gaining the normal uh, recoil of the chest wall. Okay, so that's why the patient have to work double hard, and that's why they always complain of difficulty of breathing. Okay, so the third problem that we see among patients with COPD would be your gas exchange. First is the sputum production. Second is the airway narrowing, causing shortness of breath. And the gas exchange, okay, will also cause further shortness of breath. But usually, the abnormal gas exchange would only be observed if the problem have airflow resistance have increased very, very significantly already. Usually, we do not see any blood gas changes, okay, uh, unless your FEV1 is very severely affected. So the FEV1 would be less than 30% most of the time. If your FEV1 is not less than 30%, generally you do not observe any blood blood gas changes, such as your CO, carbon dioxide, and your oxygen level of the lung. Okay, so uh, pulmonary arterial hypertensions may develop if your patients with COPD develop persistent hypoxemia. And this is because your hypoxemia, um, the hypoxemia is a very potent vasoconstrictor. So with the vasoconstriction of the pulmonary circulations, this would lead to pulmonary hypertension, subsequently lead to the right-sided heart failure, or what we call your cor pulmonale. Okay. So the main problem of your gas exchange is a VQ mismatch. Okay. So this is the essentially the reason why patients with COPD would develop a lack of oxygen. So the main problem with the oxygenations among patients with COPD is your ventilation perfusion mismatch. Okay. So, what are the risk factors for your patients to develop COPD? Number one, of course, is your cigarette smoking. Number two would be infection. Number three would be your pollutions, not only in the workplace, but also the ambient air pollutions. Okay, so these are the risk factor that usually we would be trying to look for if we suspect the patients to have COPD. Okay, so passive cigarette smoke is also a risk factor, and especially together with other genetic risk factor. Okay. So the other genetic risk factor, just like in your asthma, some of them have overlap. You can see this in the chromosome 4 and your chromosome 15. Okay. And the poor lung development can also lead to your early COPD. So that's why the etiology, if you are born prematurely or you are born with small gestational age, okay, and you have a small gestational weight, or you have frequent problem affecting the respiratory system like infection in early age, so your lung will not be fully developed, and even with normal decline you would reach this point of COPD, okay, at around 60 years old. Okay, that's why before, okay, we do not give a diagnosis of COPD unless you are 60 years old or older. But now, with the understanding that there are some genetic conditions that can hasten the drop of your lung function, this can lead to an earlier onset of your uh, COPD. Usually, a very early onset of COPD is seen among patients with multiple risk factor, not only because of exposure to pollutions, but also because of genetic factor. Okay, so combinations of your lung problem. Okay, so for the rapid decline, usually this is what we see among patients who are smoker. Okay, so non-lung smoker, we expect they have a normal development, lung development, and then they have a rapid decline in their lung function. Okay, so what are the clinical indications that makes us suspect, or the clinical manifestation that make us suspect COPD? Number one would be shortness of breath or the dyspnea. That is persistent and worse with exercise. Persistent meaning every day, all the time. Okay, of course, depending on how severe is the airway problem, but your patients with COPD would have symptoms every day. There would be chronic cough. The cough may be productive or non-productive, and the patients may also complain of recurrent wheezing. Okay, so the risk factor again would be exposure to noxious substances, uh, genetic predisposition, or developmental problem. So most patients with COPD would present with cough, sputum production, and exertional dyspnea. And of course, the if the disease progresses, this can affect the very significantly the daily activities of the patient. So it can cause a poorer quality of life. Okay. So for patients on physical examination, if they have COPD, usually you would see the prolonged expiratory phase. So what would be the pattern of breathing when your patients have the prolonged expiratory phase? Can somebody tell me? And where do you see this? In your inspection, palpation, percussion, and auscultation of the patient. Hello? Hello? Are you here?
Inspection.
Huh? Inspect, huh? In what? Where? At what at which step of the physical exam? Hello?
Inspection, doc.
Oh, so what do you see on inspection to say that there is prolonged expiratory phase? Hmm? There is?
Use of accessory muscle.
There is?
Accessory muscle.
There is what?
Use of accessory muscles.
Ah, there is use of accessory muscles. No, that is not one of the findings that tells you that there is prolonged expiration. This just tells you that the patients have increased work of breathing, the use of accessory muscles. Okay, so what findings tells you there is use of accessory muscle?
The purse slip.
Ah,
Purse slip. Like like blowing purse slip. Oh no, no.
oh, that is not use of accessory muscle. Use of accessory muscles would be the retractions that we see. Okay, the pursed lip breathing is actually the findings that tells you that the patients have a prolonged expiratory phase. So how does the examination appear? So the patients inhale and then exhale through the pursed lip. Usually it would be longer because the normal inhalation to your exhalation ratio is what? 1:2, right? So if you do your pursed breathing, your exhalation phase is prolonged. So it may now prolong become 1:3 or 1:4. Okay. And of course, if there is airway obstruction, you would definitely hear wheezing sound. But if there is significant emphysematous changes, sometimes you do not hear the wheezing sound, but actually because of the hyperinflation, you can hardly hear any breath sounds. Okay, so if there is hyperinflation, this can dampen the breath sounds and cause you to have a decrease in the intensity of your breath sounds. Okay, so among patients with COPD, if their emphysematous changes is very, very significant, then you would usually be able to observe that the patient is assuming a tripod posture. So they would be resting their head or their chin uh, on their hand. Okay, and then the elbow is rested on the knee, top of the knee. So they would appear like a tripod. Okay. We sometimes hear the word pink puffer and or your blue bloater among patients with COPD. The pink puffer is usually somebody that this phenotype would be usually somebody who is thin, okay, and very pinkish, not cyanotic, and then the patient is very short of breath. So that's why they are puffing all the time, but in spite of having shortness of breath, they are not cyanotic. For blue bloater, mostly this would be those patients who have predominantly chronic bronchitic changes, so they would usually be cyanotic and they are short of breath and blood bloated. Okay, so they are termed your blue bloater. Okay. So if your patients have very advanced COPD, then there would be wasting. So there would be significant weight loss. This weight loss is not only because of the decrease in food intake, but also because of the effect of increased circulating tumor necrotic factor. Okay. And if the hyperinflation is very significant already, then you can see the Hoover sign. So that means there is inward drawing of the lower part of the thoracic cage during an inhalation instead of the outward movement of the thoracic cage. And if your patients have prolonged hypoxemia, this can lead to your pulmonary hypertension. Subsequently, this can cause your patients to end up with your right-sided heart failure, or what we call your call pulmonale. Clubbing is not a sign of COPD. So we do not see clubbing among patients with COPD. Okay? Now, how do we confirm? We do a pulmonary function test, spirometry, just like among patients with asthma. And of course, the expected findings is that there is a drop in your FEV1 over FVC, and there is a persistent drop FEV1 over FVC of less than 70%. Okay, if the patients have these findings, then we know the patients have COPD. Okay, so other diagnostic tests we may request, maybe we can request for your CBC, chest X-ray, and if you suspect a genetic problem, alpha-1 antitrypsin. Of course, if you want to check how severe is the blood gas problem, then we have to check the arterial blood gas. Okay, so uh, just a moment. Okay, this is the okay. So if your patient have persistently low, okay, FEV1 over FVC, then we can further subclassify the severity of your airway obstruct into mild, moderate, severe, or very severe by taking note of the drop of your FEV1. If your FEV1, even if they have, if the patients have low FEV1 over FVC, the patient may still have a normal FEV1. So in this case, we would say that patients have mild airway obstruction. Moderate airway obstruction would be an FEV1 of between 50 to 80% of the predicted normal, while severe would be 30 to 50% of the predicted normal, and very severe less than 30%. So it is on the severe or very severe where we expect to see patients who would present with hypoxemia or hypercarbia. Usually, you develop hypoxemia first prior to the development of hypercarbia. So, if your patient started to develop persistent hypoxemia and it is and a patients frequently still short of breath, that means they have severe uh, airway obstruction, and they are very near the um, end of the disease entity of COPD, especially if they also have concomitant retentions of carbon dioxide. Usually, you would not be able to see the patients anymore for their next appointment if they are retaining carbon dioxide already. So that is already very late stage of the disease entity already. Okay. So during assessment of patients with COPD, we also take note of comorbid conditions. Okay, because most patients with COPD are elderly, definitely they would have metabolic problem, cardiovascular problem, and quite a few of them actually their demise is because of a cardiovascular problem. Okay, with the poor activities that they can endure, okay, or alter a significant change in their daily activities, sometimes the patients may also have depression, anxiety, and because again of the decreased food intake, the patients may be wasted okay, or have significant weight loss, and or the patients may also uh, develop osteoporosis. Okay, and since the number one risk factor that we usually associated with COPD is cigarette smoking, so cigarette smoking can also cause a very significant increased risk of the development of lung cancer. That's why among patients with COPD, we are always at the lookout for the possibility of lung cancer. Okay, so that would be the problem among patients with COPD. Okay. So we also assess the severity of your patient's case symptoms, not only the shortness of breath, but also the other clinical manifestations such as cough and sputum productions of the patients. Okay, how energetic the patient is. Okay, as part of the assessment, and thereby we can use this not to help us classify your patient's severity or the category of your patient's COPD, and based on the assessment of these patients, we also can help them with the medications indicated. Okay, the different indications of the medications. Okay, so one of the assessment that we use, what one of the questionnaires that we use to assess the symptoms, subjective symptoms of patients with COPD would be the CAT. Okay, COPD assessment test. That's the CAT. Okay, we ask, it's a questionnaire wherein we ask the patient to answer them themselves. Okay, and then we add up all the score based on your one, two, I think seven. One, two, three, four, five, six, seven, eight. Eight questions. If your patient score on the SCAT assessment is equal to 10 or more than 10, okay, total point, then that means your patients have significant symptoms of COPD. Another assessment that we can use would be your MMRC dyspnea scale. So this is also the dyspnea scale of your American Thoracic Society. So in your American Thoracic Society, we grade them as mild, moderate, severe, or very severe. But in the British Thoracic Society, they grade them this as grade 0, 1, 2, and 3. So based on the MMRC dyspnea scale, if your patients have a score of 2 or more, that means their symptoms is already significant. So if you compare the CAT and the MMRC, I'm sure you would agree that the CAT is more tedious, harder to answer compared to your MMRC. So an MMRC is usually assessing the patient's ability to walk. So it's very easy to use. Okay. So if your patients have a grade of 2 of dyspnea scale, grade 2 of dyspnea scale, that means they have very significant symptoms. So after knowing that the patients, suspecting the patients to have COPD based on the symptoms of dyspnea, cough, sputum production, okay, and then confirming the presence of persistent airflow resistance, and then the symptoms, we can now more or less come out with the as to how severe is your patient's COPD. But we also want to take into account the frequency of exacerbation. So if your patient is a frequent exacerbator, then it is advocated that we have to give your inhaled steroids. Okay, so this used to be the assessment tool that we do. And we, after assessing the patient, we categorize the patients into A, B, C, and E. A, B, C, and A, B, C, and D. But now we only have A, B, and E. So we merge your C and D. This C and D group of patients are those frequent exacerbator. So frequent exacerbation is defined as equal to 2 or more exacerbation per year, or equal to 1 or more than 1 exacerbation that need hospitalization in the past year. So that would be your frequent exacerbator already. So we have A, B, and E. No more C and D. Okay. So based on these new classifications, A, B, C, A, B, and E. Okay. For A, it is advocated that we give to help the to decrease the shortness of breath of the patients. They recommend the giving the patient bronchodilator. If your patients belong to group a category B, that means they have more symptoms but infrequent exacerbator, and their advice is to give a LAMA-LABA combinations, a long-acting beta-2 agonist and a long-acting muscarinic agonist. Okay, so that is their advocate. Okay, and if your patients have frequent exacerbation, whether they have significant symptoms or non-significant symptoms, their recommendation is to give lama laba. And if the blood absolute eosinophil count is more than 300, then they would advise thus to start the patients already on your inhaled steroids. Okay, they found out that amongst frequent exacerbator, the use of inhaled steroids can decrease the number of exacerbation and the severity of your exacerbation. Okay, so that is your bronchodilator. And what bronchodilator do we give? The LABA or the LAMA? Okay, for COPD, it is advised to give the muscarinic agonist rather than the beta 2 antagonist. Okay. Okay. So, the goal of treatment, just like in asthma, is to reduce symptoms. If you reduce symptoms, you also reduce the risk of mortality of patients with COPD. Okay. So far for treatment, the only proven effective treatment that can prolong survival among patients with COPD, number one is stop smoking. Number two is prolong, okay, home oxygenation. So that means, okay, if you're short of breath and you need persistent or need supplemental oxygen, okay, then it is advised that you have to receive supplemental oxygen. And usually, how long do we need the supplemental oxygen? This would be at least 18 hours, 18 for continuous oxygen treatment. Okay, so we do not want the patient to go to the zoo, right? Why? Because the patients may have infections or get allergens from the animal. Another treatment that have been shown to improve survival would be your uh, lung volume reduction surgery. Okay, this would depend on the destructions of the lung and how big are the bullae of the lung. Okay, so that would be the three interventions that have shown significant improvement in survival rate. Okay. So aside from the management that we can give to your, aside from your cigarette cessation, we can also give bronchodilator, okay, as a maintenance or as a reliever medicine. For the maintenance, we give your long-acting bronchodilator. As acute exacerbation, we give your short-acting bronchodilator. And together with this, we also give your anti-inflammatory drugs if your patient is a frequent exacerbator. Okay, so the available NAMA-LABA class combinations that we have in the Philippines would be your indacaterol, glycopyrronium, vilanterol, umeclidinium, formoterol, and your theotropium, or lolodaterol and your theotropium. So these are the LAMA-LABA available. And we, of course, we would advocate the use of your once a day Lama Laba to improve compliance, survival also of your patient. Okay. So, and we give this in the morning so that the patients would have a better quality of life. They would be able to move around during the waking hours. Okay. So this is already set. I've already told you that if your patient is a frequent exacerbator, then it is advised to start your patients on inhaled steroids on top of your lama laba. So that means the patients belong to category E. But sometimes we cannot give your steroids, especially if your patients have frequent pneumonia or the patient's lung infection is because of pneumonia. Frequent uh, in lung lower respiratory tract infection, and another contraindications would be okay if the patient's problem is frequent exacerbation, okay, and eosinophil count is more than 300 or equal to 300, then it is advisable that we start the patients on anti-inflammatory medications. So other medicines that you can try would be your roflumilast. Okay, the problem with roflumilast, it cannot be used in acute exacerbation. Generally, it is used more for patients with chronic bronchitis rather than your emphysematous changes of the lung. Okay, so in patients with chronic bronchitis, they have shown some improvement in their FEV1. Okay, so that would be your roflumilast. If your patients, okay, have predominantly chronic bronchitic type of problem that leads to the development of your COPD. Okay, so we okay, first diagnose, then we give the assess the patient's severity, start the initial treatment. After a week, okay, we ask the patients to go home and try to maintain their medications and come up afterward and check again on their exercise ability, other activities that is limited before, and of course, very important would be for us to, okay, check on the patient's use of their inhaler. Just like your asthma, because most of our medicine is given through the inhalation drug. So if your patients do not know how to use the inhaler, that would be a big problem. Okay, so aside from giving the inhaler, we also want to prevent disease. So we recommend vaccine and treat the comorbid conditions also. And on follow up, we check on the patient's symptoms, check on the patient's ability to use their inhaler. It's very important to check on this. Okay. So we adjust the medications if the patient still have a lot of symptoms, or we decrease the amount of inhaler being used by the patient. Okay. So other treatment would be your pulmonary rehab. Okay. Okay, it may not improve actually your lung function, but it certainly improve the well-being of the patients. Okay. Lung volume reduction surgery would depend on the what happened in the lung. So if there is very big bully, then usually the patients would benefit from lung volume reduction surgery. Okay. So in lung volume reduction surgery, okay, we will not go through this one by one, but you just read about it. You can also request for a lung transplant, okay, especially if your patients, if you have very significant lung problem. Okay, let's go to exacerbation. So exacerbation is classified into mild, moderate, or severe. Mild and moderate is usually treated on an outpatient basis. And for mild, usually we just give additional bronchodilator. For moderate, aside from additional bronchodilator, we also give your antibiotics and your um, antibiotics and your short-acting bronchodilator. Sometimes the patient exacerbation is quite severe, that means they would need hospitalization. So some of them may even have to be hooked to a mechanical ventilator. Okay, so in patients who need hospitalization, we further classify them to whether to be in respiratory distress or not. Okay, in the patients have respiratory failure or not. Okay, so the frequently, the diagnostic, differential diagnosis among patients with worsening of symptoms during exacerbation. So for more frequently entertained would be your pneumonia. Okay, the patients may have heart failure, or patients may have emboli, or the loss of your function, maybe because of air pollution, okay, or because of other pollutions. Okay. So we also always have to check on this. So if your patient needs hospitalization, okay, and the patients have problem with their breathing, we can also try to hook the patients to a non-invasive mechanical ventilator. Okay, so when do we hook the patients to a non-invasive mechanical ventilator? If your patients have respiratory acidosis, severe difficulty of breathing, and persistent hypoxemia despite supplemental oxygen, then we would can try your non-invasive mechanical ventilator. But we have to reassess and check whether the patient is improving or not. If the patient is not improving, then maybe you have to really hook admit the patients to the ward already. Okay, do not delay further. Okay. So, for invasive mechanical ventilation, usually if your patients fail to improve with the non-invasive mechanical ventilation, then this is the time that we have to hook the patients to invasive mechanical ventilation. Usually, it is indicated if your patients develop cardiorespiratory failure or cardiac failure alone, or respiratory failure alone. Okay, so this would be, and the patients is uh, problem is not relieved by the airway. Okay, that would be another indications for it. Okay, any question?
None po.
Okay, so let's have what's the time now? Okay, let's have a 10 minutes break. My time is 2:40, so 2:50. So we will now go to ARDS. Okay,
Okay po, Doc.
thank you.